Objectives.
Okay, so these are the objectives. Objectives is talking about the skin of the hand, sensation, then attachments of the muscles, action and clinical testing of the hand muscles, then flexor extensor retinaculum, then there are spaces, then there are boundaries of the carpal tunnel. Carpal tunnel is very popular in medical. Blood supply, nerve supply, palmar epineuritis, sheath extensor expansion. This is again important because so many questions comes. Why this is not working? Okay, easy part. This you can understand and memorize. There is no concept for this. So D fascia, numerous fibrous bands, and slow shows many flexure creases at the site of skin movement. Flexure creases, all these your lines, sometimes lucky lines, sometimes not. So skin of the dorsum, sensation. Whenever the skin comes, which type of sensation it carries? Whenever the skin comes, which type of sensation it carries? General sensation or special sensation?
General.
What are the general sensations? General sensation, name? Hotness, yes. Touch, pain, temperature, pressure, vibration, right? So these are all. Come to flexor retinaculum. Retinacula, what is this? It's a condensed, means thickened D fascia, right? Particularly at the wrist area and the ankle, right? Ankle joint, wrist joint. Okay, flexor means it is on the anterior side, extensor means it is at the back side. This is in the dissection. Which area is this? Which region is this? Yes, the wrist joint, right? It is not the hand, it is not the forearm, it is the wrist joint. Now you can see this is the dense fascia, and in the cut section you can see this bridge. This bridge is attached medially and laterally. This is the thumb with the number 1, right? So counting starting from 1. So this is the lateral thumb, this is the medial little finger. Here the carpal 4 and 4. So which bone is this? First one? Pisiform on the medial row, and in the distal row, hamate, right? So here hook of hamate is visible. There is a ligament between these two. There is a pisiform and there is a hook of hamate, and there is a ligament here, right? This ligament is sometimes called as piso-hamate ligament, and this ligament forms a roof of a tunnel. What is the name of this tunnel? Piso-hamate ligament, piso-hamate tunnel, or Guyon's tunnel, right? G-U-Y-O-N. Guyon's tunnel. This tunnel is actually a gateway for the structures, particularly the ulnar nerve and ulnar artery. There is a gateway to enter into the hand. There is the ulnar, right? Little finger, ulnar nerve, ulnar artery. It is going here. And this ulnar is the main supplier for the muscles of the hand. So it has to enter into the hand. But for entrance, it needs to pass through a gate, a tunnel. So that tunnel is this, between the pisiform and the hook of hamate. And both of them, they will travel through here and then enter into the hand area and supplying most of the muscles. So this is the important Gaon tunnel. Okay. Now, so here this is the medial side, this is the lateral side. Medially this flexor retinaculum is attached to the pisiform and hook of Hammond, and laterally it is attached with the
Scaphoid.
scaphoid. Yes, that is the tubercle of scaphoid and trapezium. As you remember, you will appear in the exam. Right, Killian? So any problem with the flexor retinaculum?
Easy.
Right. Okay.
You mean examine the patient or the paper?
Now, exam soft. It's a very soft exam. Don't take it hard. The name is saying soft exam. Right? It will kill you, but very softly. Okay. Now, carpal tunnel. Just like we discussed about the Guyon's tunnel. Guyon's was the scientist. The other name was P.C. Hammett tunnel. This is the carpal tunnel because it is forming in the carpal bone. So if you see the cut section, you can see the bones here that form the roof and the lateral wall. Floor and the lateral wall. And this is the roof formed by the flexor retinaculum. Which bone is this? Pisiform, right? And below the pisiform actually sit on the triquetrum, right? So okay, pisiform, triquetrum, these are the first raw bones on the medial side. Laterally, this is the scaphoid. So what happens in the first row? There are only 4 bones. So how many bones are here? 1, 2, 3, 4, 5, 6 bones.
There are 2.
Huh? Yes, how it is possible? This is my question. As an anatomist, you tell me this diagram is right or wrong?
It is right, but the level, we should go more distally.
Achha, you're cutting with the distal raw.
Yes.
Distal raw, it means the hook of Hammett will come. Pisiform should not come.
Maybe not the hook of Hammett.
So if we
Then,
Maybe
yes, I'm just asking because when I saw this picture, I was confused. Yeah, what is this? It should be 4. Why it is 6 here? So then I saw the, yes,
Maybe because it's in between the layers.
in between the layers means
Between the distal and the proximal.
the blade will go either distal or proximal. Maybe oblique, but it is not oblique. Yes. The thing is that the proximal row and the distal row, in our imagination, we take it 4, 1, 2, 3, 4, distal and proximal 1, 2, 3, 4. Right? But this is not right. The proximal one is not horizontally placed, it is U-shaped, like. So this pisiform and this scaphoid, they are anterior, right? And this lunate and triquetrum is a bit posterior. So it is something U, and then the 4 bones are here. The middle one, capitate, is the largest, so it occupies the central portion. So when they cut, you are cutting actually leaving these 2, right? So you are including another 2. So that's the reason the angle of cut is actually including some bones of the distal raw. That's why it is appearing 6 bones here, right? So this is the logical explanation of this section, right? Okay, back to the exam. Carpal tunnel formed anteriorly by wrist. Carpal bones inferiorly, I think this, you know it. Any problem with this? Right? Yes, you have to read because I don't want to teach sentence by sentence. So what I delivered, just delivered. And it's better for me, my point of view, to give you the concepts. Right? This you can understand at home also. This is another very powerful slide for exam point of view. where the examiner usually examine you, just memorization, right? What? Can you see this line? This line is the cutting line, right? And this upper picture is the cut section at this line, right? But both the pictures, they are oppositely placed in lateral and medial sides, right? Thumb is here, it means this is the lateral, the little finger, the medial. Here, this is radius, this is ulna. Radius is lateral, so lateral is this, and this is the medial, right? So here lateral is here the lateral is here. So just keep this thing at one point in your mind. Second, now come to the contents of the compartment. Compartment 1. Can you see this 1, 2, 3? 1, 2, 3. These 3 tendons, they are bounding the snuff box, right? And how we memorize the snuff box muscles?
One medial, two lateral.
One medial, yes, two lateral.
One medial, 2 lateral.
Yes.
Okay. Another easy way is, that is the exam point of view. But as far as the insertion of these 3 muscles are concerned, it will be very easy to remember that longus, brevis, longus,
Longest,
Yes.
brevis, longest.
Longest, brevis, longest.
right? So for longus, this is the longus going to the distal phalanx, right?
Yes.
And this forms the medial boundary of the snuff box in the posterior direction. So this is one longus, very long. Then comes the brevis. Brevis is this proximal phalanx. This is going to attach the distal phalanx. This is going to attach to the proximal phalanx, right? Then the third one is
At the base.
abductor, again longus. Abductor pollicis longus. So longus, brevis, longus. Or longus, brevis, longus. So it's easy, longus, brevis, longus.
Right.
And so these are the snuff box boundaries. Now first 2 in compartment 1 are these 2. So in the cut section, compartment 1, extensor pollicis brevis and abductor pollicis longus, right? Easy. Then come here at the side. Here now come 2 cousins attached to the second and third metacarpal. And these 2 cousins, they are coming from the very beginning together. Extensor carpi radialis longus, extensor carpi radialis brevis, right? So here at this cut section, these 2 cousins, they are falling in second compartment, right? Third, this longus, the medial boundary of the snuff box, this is very tricky. It has to go on the left side, but it is coming from the
Right.
medial side, right?
Goes above the-
But this is very single, very dodgy. So this is the single one. So this is the compartment, third compartment alone. In the exam, they ask you questions like this. Which of the following muscle passes through the third compartment of the extensor ventricle? So similar like this. Then this is easy. Digitorum, and this is going to the digiti minimi, okay? And this is the last one, very extreme. So this is the radialis, so here it was the ulnaris. So extensor carpi ulnaris, right? So by this you can understand, right? Okay, another thing, attachment of the extensor retinaculum. This was the extensor retinaculum. The medial attachment, this is same as the attachment of the flexor retinaculum.
Both are the
So
same.
flexor retinaculum and extensor retinaculum. On the medial side, both of them, they are attached to the pisiform and hook of hamate, right? Laterally, going here, it is attached to bone, right? Radius. Yes. Who is the class leader? Is there any class leader here in medical college?
We
No,
have
we're
a
democratic.
Democratic? So you must be fighting with one another?
our leader is a ghost. Just in this one. إيه مكرر بداية مكررة.
So it automatically closes or what?
I don't know why, but it happens with your account only.
ايوه بس في حسابه.
كذا في 5 دقايق بعدين يطفي. ممكن حاجة في السيتنجز. لا ممكن شيء.
ترى بدي يسوي بريزنتنج ما يحتاج يكون سكرولينج صح؟ ايوه
Okay, at least by this mistake, now it is working. MashaAllah. This is called blessings in disguise.
What?
Right? Blessings in disguise. You become worried, oh, what happened? Why it is closed? But by new way you open and you are blessed with the
حصل خير.
oh, the range is the problem. Okay. Okay, any question with this compartments? No? Okay. I sometimes go slow, but to be honest, it's more easy to understand when going slowly. Otherwise, now here, what is this? Synovial sheath. You know all what is synovial, wrapping upon a tendon. But what question comes here? Look at the pattern of wrapping. This is the synovial sheath wrapping the whole tendon of which muscle? This is the flexor area. Lumbricals are here. Yes, flexor pollicis longus. So the question, flexor pollicis longus, all tendinous area is covered by the synovial. Then second, fully covered, digiti minimi, right? So this digiti minimi and pollicis, their tendons are fully covered by the synovial sheath. But the second, third, fourth, they are only covered at the digits or at the palm area. There is an open tendons here. This is a risk. So most of the infection can go easily through this area, but this area also provides some, in the flexion, it makes your life easy in flexion, right? So this is the synovial sheath. Fibrous sheath. Look, how many sheaths? Fibrous sheath. So all this synovial membrane that is wrapping around the tendon is not safe. Just to give us safety, it is further enveloped or wrapped by a fibrous thick sheath, right? So this sheath, this is the cut section of the same sheath. There is one sheath showing from the distal to the proximal phalanx, right? And all these sheaths individually, they are connected by this longitudinal ligament, right? So they are all connected together. Okay, now this sheath and under this sheath, there is a synovial sheath, right? So fibrous sheath, synovial sheath. Now cut this fibrous sheath into half, all like this, and see the base. When you see the base, these fibrous connective tissue, they are attached with the bones, phalanges. But at the joint and between the joint, there is a difference. These are the transverse fibers, right? And these transverse fibers, they are mostly at the joint. But between the two joints, it's a crisscross, cruciate. Right? So these are the cruciates. So cruciates are along the phalangeal bone, the body, and at the joint you will find the, so formed by fibrous arches and cruciate ligament. So fibrous arches are where? At the joint. So this will form the arch. Same. Clear? Yes.
Why do we have 4 cruciate instead of 3?
1, 2, 3, 4. Oh, did not draw this picture. Okay. So, hold tendons to bony plane and prevents tendon from bowing. Bowing means bending. Now, extensor expansion. This is also a very popular topic in the examination. And on the Viva table or on the OSCE, they must ask this thing in the hand. If you are a good student, this is your question, right? Now, what is this? Extensor expansion is also called as dorsal expansion. Dorsal means backside. So hand, back of the hand, right? So extensor expansion. Expansion, something is broaden up, right? If you see dorsally, extensor digitorum tendon, right? They are going to the 4 digits. And how they insert on the digits? What is the pattern of insertion?
It divides into 3 divisions. Let's say medial, lateral, and median. The median one or the intermediate one stays at the middle phalange. And the lateral 2 or the lateral and medial one goes like a pyramid and forms an apex at the distal phalange.
Very good. Excellent. But nobody else who are new, they understood what you have said.
I know.
Right? That's why this is anatomy. Anatomy, if you miss the things, anatomy can only be memorized in 2 ways. Either you build a concept or you link it with a clinical case, right? Otherwise, anatomy in 1 month, inshallah, you will be relieved. Okay, now this is the extensor digitorum coming here, and you see this is the distal phalanx, this is the middle phalanx with the dots, and this is the proximal phalanx, and here is the metacarpal, right? Okay, this tendon coming here, which joint is this? Metacarpophalangeal joint, right? When this tendon come here, it divides into 3. One you can see this one going straight, and 2 are going to the corner side. This one and this one. These 2 are the 2 flaps, and ultimately these 2 side ones, they unite together to insert to the base of the distal phalanx. Right? So it is like this. This is the middle one, and
Stays
these
in
2
the-
are the lateral. This middle one is inserting here to the base of the middle phalanx, right? But the 2 lateral one, they go on the side of the middle phalanx, have some attachment to the middle phalanx, but ultimately they unite and form a single insertion to the distal phalanx, right? Now this is the posterior view, and all things are on the back of the hand, right? If you pull the distal phalanx from the back, which action will be done at this interphalangeal joint, distal interphalangeal? Extension or flexion? It will bend or or it will be extend.
Extension.
Extend, right? So anything, if you are pulling him from the back side, so where he will go? To the back,
Go backwards.
right? So same, if you are pulling the distal phalanx from the back side, it will extend, right? It will not bend.
Yes.
Clear?
Yes.
Or, okay, if this is a 2 rope, have you done riding? How many of did the riding of horse riding? 1, 2, 3, 4, 5. It's very exciting and it gives you confidence, right? So do and train sometimes if opportunity comes. the two ropes, they are going on the side, and they are attached with the head or mouth, right, we say, and whatever you pull, Allahu Akbar, whatever you pull, it goes to right or left. Here again, there are two ropes going side by side. So if you pull any rope, so what will happen? The two ropes that are joining at the distal phalanx, it will lift the distal phalanx, right? If you are pulling these two ropes from the side or backward, so what happened? The distal phalanx will flex or extend? Still extend, because you are pulling from the back side,
Yes.
right? The two ropes that are there on the side, you are pulling it, what will happen? It will not bend, it will extend, right? So remember, distal interphalangeal joint and proximal interphalangeal joint. These two joints will be extended when this two rope will be pulled back, right? So without picture, this happens with every class? No?
Only us.
Who is the leader of the class?
He's not here.
This is not fair, man. I will complain that the guests are not. Oh, sorry. At least it is open. Okay, come back to the topic. This is the superior view, lower picture, and this you understood here that if this side or this rope, if you pull it, this distal phalanx will extend. Similarly, the middle phalanx will also extend. So these two joints will go into extension. Proximal interphalangeal joint and distal interphalangeal joint, right? This is the superior view. Now come to the metacarpophalangeal joint, right? Here you can see a merger of tendons of so many muscles. Lumbricals, interossei, right? They are all at the corners. And if you see, the shape of this expansion is like a pyramid or triangle. The base is broad here, and then it is tapering here. So this is a pyramidal in shape or triangular in shape. So this is the base, and the base has got two ends, corners, this and this, medial and lateral. And to both the corners, the muscles are attached to, right? Now here, this is called expansion. This combination of tendons, this is the hood. Have you heard hoodie?
Yes.
Right? So this hoodie is actually covering this joint, metacarpophalangeal joint, right? You do it? Yeah, mashallah. So you have covered actually the metacarpophalangeal joint. But this extra hood is coming from the pattern of insertion of the tendons, right, of different muscles. So there are more here. So this is the expansion area and this is the taper area. So this is called as the dorsal hood. Just like here, extensor hood or dorsal hood. So hood is actually the dense merger of the tendons of different muscles. Okay, this is at the metacarpophalangeal joint. Now, you are pulling this lumbricals and this interossei. Particularly, although what the picture is here, if you take it like this, at least for these two, we are clear. Now come here. The interossei, the palmar and dorsal interossei plus lumbricals, they are here in the front,
Yes.
right? Now look at the position. From front, the muscles are attaching to the lateral side and they are pulling it from where? From the back side or front side? Front side, right? So when they pull it from front, the metacarpophalangeal joint, they will bend,
Yes.
right? So flexion will be here, but the same lumbricals and interossei, when they pull the lateral, this rope, what will happen to the proximal and distal interphalangeal joint? They will extend. So actual picture will be like this, right? Extension of the proximal interphalangeal joint, extension of the distal interphalangeal joint, and flexion of the metacarpophalangeal joint. Because this, can you see this muscle? This is the dorsal interossei, right? So this is the function of the dorsal expansion, right? Dorsal expansion is formed by the contribution of which muscles?
Interossei.
Yes, lumbricals, interossei, dorsal and palmar, plus this, yes, extensor digitorum longus, right? Now tell me, if these muscles that are pulling and doing from the lateral side, so actually these lumbricals and interossei, they are doing this thing,
Yes.
right?
Yes.
If there is nervous paralysis, nerve injury to these muscles,
Mm.
can it possibly do this thing?
No.
They cannot do. So what will happen in the actual picture? It will be totally reversed, because the muscles that are pulling from the here to the lateral side, now they are paralyzed and no one is pulling it from the back side. So the flexor digitorum profundus and flexor digitorum superficialis, they will become dominate. So here in the proximal and distal, the finger will appear like this, right? Clear? Okay. Now come to this metacarpophalangeal joint. When the lumbricals and interossei, they were acting, so it was bending the metacarpophalangeal. Now they are paralyzed. Interossei and lumbricals are not working. They are not pulling from the front, right? Then what will happen? The dorsal, these tendon, dorsal or extensor digitorum longus. Extensor digitorum longus. What is the nerve supply of this muscle?
Radius.
Extensor digitorum longus.
Radius.
Radial.
Radial, right? It is not the ulnar. So this interossei and lumbricals, they were innervated by the ulnar. Ulnar nerve got injured, right? So those who are bending it, they cannot bend it. While the extensor digitorum longus, that was here, it is supplied by the radial. So radial is intact. So it will extend. So what will happen? It will extend at the metacarpophalangeal joint and flexion at the distal and proximal interphalangeal joint. And the picture would be like this. Extension here in these two areas, and these two areas will be flexed. These two not. Why? Because they are supplied by the median, right? Ulnar is supplying to two lumbricals, lateral two or medial two, right? And lateral two lumbricals and the flexor digitorum profundus, they are supplied by the median. Ulnar is supplying 1.5 muscle, flexor carpi ulnaris, and the medial two of the flexor digitorum profundus. And from the profundile tendon, lumbricals are arising. So the two medial lumbricals that are arising from the medial two flexor digitorum profundus, right? They are all paralyzed. So ulnar nerve injury will be like this. Extension here and flexion to these two, right? These two, no effect because they are working. But this remains as a permanent picture of the patient with the ulnar, right? There is another situation in the median nerve injury, right? This you understood, right? Now come to the median. Median is also giving the same type of situation, but this is not a permanent sign. In ulnar, this is always permanent. When your hand is relaxed or working, acting or non-acting, in both the situation, it will be like this. Extension at the medial 2 and flexion at the medial 2, proximal and distal interflexion. But in the median nerve supplies what? The other lumbricals, right? And the median nerve is actually supplying the remaining flexor
Muscles.
digitorum profundus, right? Now, and median nerve is also doing this flexion, right? So if median nerve is damaged, flexion will not occur, right? Okay, so when the person wants to flex something, he cannot flex. And only when he want to flex, extension is okay, because radial nerve is working fine, right? Only when he want to flex or form a fist, then what will happen? Again, the same picture. These two will flex. Why? Because it is innervated by the ulnar. These three, they will not, right? Because the median nerve injury. So median nerve to the lumbricals here, these lumbricals, they were making the bending of the metacarpophalangeal joint. So these lumbricals and trochei, lumbricals particularly, they will not work on these two fingers. So when the patient with the median nerve, he want to flex all the fingers, he cannot, because he cannot bend this metacarpophalangeal joint here. So at that time, he can bend this and this. And this is only when he want to form a fist. Normally, yes, resting, it will be fine. But when he want to make a fist, no. Only these two will bend, these two will not bend, because these two ulnar nerve innervation intact, so it will bend the metacarpophalangeal joint, and these two will not bend because the lumbrical of these two are not innervated by the ulnar.
Doctor, we said those are innervated by the ulnar. If the ulnar is injured, he won't be flexing these two. So why it is not like this? Because he won't be flexing those. Because the ulnar is innervated.
Here, these two, the radial and the ulnar, both are working fine,
Okay.
right? So for these two, no problem. They will bend in the median nerve injury, right?
I mean in the ulnar nerve injury.
In the ulnar nerve injury, because lumbrical is actually the main one, those who are acting on the proximal and interphalangeal joint.
Okay.
So they will bend because the lumbricals, they are anterior, but they are pulling from the back side of the dorsal expansion,
Okay.
and they were doing extension at these 2 points.
Okay.
So now there will be no extension, only flexion will occur, because here there are powerful flexor digitorum profundus, flexor digitorum superficialis. So they will make it bend, these two. But here at the metacarpophalangeal, the lumbricals and all these interossea that were pulling it from the front, in the ulnar nerve, they are paralyzed. So they cannot bend the metacarpophalangeal, they will be hyperextended. So hyperextension here and flexion at these two, just opposite to the function of the dorsal expansion.
That's when the patient wants to do what? A fist?
This is a permanent. When ulnar nerve here injury, this is permanent. Whether his hand is resting or working, flexing, fisting, no change. It will remain as it is. But in the median, there is a problem. But only when he want to fist.
Okay, in the median, it's not going to be the same thing. If there is a median nerve injury, he will not be able to flex the metacarpophalangeal joint. But will he be able to extend the distal phalangeal?
Extend.
Yes, this one. Like normally. This one is normally extended.
Normally, it will be extended. Yes.
In case
of
median nerve,
fisting, making
yeah.
the fist, yes, because he cannot bend it. Median nerve injury, here on these two fingers, the median nerve is supplying the lumbricals,
Okay.
right? While all are supplied by the ulnar.
Ulnar.
So these lumbricals are not working.
Okay, no flexion.
No flexion.
Here.
Yes,
What
metacarpal.
about here?
Here, yes, there is some possibility.
some flexion?
Yes, or the flexion.
Okay.
But usually, when the lumbricals are not working, and so the extension part of the lumbrical is actually nullified.
Okay. So it
So
will
the
flex.
flexors,
Yeah.
they can flex,
Mm.
but since this is not flexing, so only these here they can flex slightly,
Slightly.
right?
Okay.
But since it is not flexing, so it appears like this.
Ah.
When they want to fist hold something, only he can hold, these two will bend, these two will not come bend, because this metacarpophalangeal joint is not bending. So here it can bend and it can flex more. Here slightly it can bend, but these two no.
Okay.
Can they do this? Well, this is extended,
Mm,
but this
it is possible.
Doctor.
So many things. It depends on even the nerve injury. What we think, only one entity, nerve injury, yes, nerve injury. No. At which site the nerve is injured? Because one nerve is giving so many branches. So which branch will suffer or which branch will not suffer? If the nerve has given branch and then it is injured, so this branch will work, right? But only the distal will not work, right? But if it is proximal, then every branch will not work, right?
Lumbrical.
You are taking time or I am taking time?
Lumbricals.
Okay, just enjoy the things, that's all. I don't know when you will find it. Now come to the slide point, apex, central and corners. These are triangular dorsal expansion or extensor expansion. Triangular means same pyramidal, right? So apex attached to the distal phalanx, central region attached to the middle phalanx in the digits, and proximal phalanx in the thumb. Corners that are the extensor hood, right? So this is the hood here. No hood, no hood, no hood. Hood is at the metacarpophalangeal joint, like this, right? So this is the hoody area that is covering the joint, wrapped around the sides of the metacarpophalangeal joints. Just close. Palmar epineurosis, I think this is very easy. So apex, so this is the palmaris longus muscle crossing the fibrous flexor retinaculum. It diverges, it forms a triangular structure. Some fibers are longitudinal, going to the and continuous with the sheath, right? Synovial sheath, and these are the transverse fibers. What is the purpose of this epineurosis? Is to provide roof or safety to all the
muscles and nerves.
Can you see this one muscle, palmaris brevis? This is very similar to the platysma here in the neck. Platysma in the neck, right? It is originating from the clavicular area and this, but it is inserting to the skin. So palmaris brevis is also taking origin from the palmar epineurosis, flexor retinaculum, right? But here it covers the hypothenar muscles and on the medial side it insert with the skin, the dermis of the skin, right? So this is a safety factor only. So muscles of the hand muscles. What are the name of the muscles? If you remove the skin, there is the thenar, there is the hypothenar, right? So in anatomical position, thenar and hypothenar. What muscles are there? So there are 4 short muscles, 3 short muscles with a little. So hypothenar here, thenar with a thumb, and hypothenar, 3 muscles. And then we have got the lumbricals and interossei. Nerve supply we'll do. Come to the one by one. Short muscles of the thumb. short muscles, thenar. Total number of muscles is 4. But there is a discrepancy, there is a problem that 3 muscles are innervated by the median nerve and 1 muscle is innervated by the ulnar, right? So sometimes for memorization, we make one formula, a very short word, FAO, F-A-O. Just remember these 3. F-A-O, FAO, right? Now this will help you in memorizing the name of the muscles of the thenar and hypothenar, right? These are the name, first letter of the 3 muscles, both in the pollicis and the digiti minimi. So you know this is digiti minimi and this is pollicis. So thenar with the pollicis, hypothenar with the digiti minimi. Since both are originating and inserting in the hand, so they are all brevis, right? Now F, flexor, pollicis, brevis, and for the digit, flexor, digiti minimi. A for abduction. So abductor, pollicis, brevis, abductor, digiti minimi. O, opponens, pollicis, right? Or opponens, digiti minimi, right? So F, A, O. So here there is the thenar, and these are the F, O, A, not in this sequence, but you have to remember flexor, pollicis brevis, abductor, pollicis brevis, and opponens, pollicis. All pollicis, because you are talking about the thenar muscles. Okay, one muscle is outside because it is innervated by the ulnar nerve. These 3 muscles, they are F-A-O, FAO, Fa-ulaika, FAO, right? So Fa-A-O, so that is innervated by the median nerve. Okay. This we will more discuss one by one. Acha. So 3 muscles of the thenar muscles. This is the 4th one that was innervated by the ulnar nerve. But what is important anatomical examination point of view? Name the artery that is passing through the 2 heads of the adductor pollicis. So adductor pollicis is this 2 heads, transverse head and oblique head. Transverse head, oblique head. And between the 2 heads, this artery is a branch of the radial, right? Thumb, radial artery. And radial artery, what is this arch? Deep palmar arch. So deep palmar arch of the radial, actually it is coming in the deep side of the palm between the passing through the 2 heads of the adductor pollicis, right? Origin insertion is the same, just remember this middle one. 3rd metacarpal, it gives transverse origin, and 3rd metacarpal and this capitate, it gives the oblique, and both of them they are inserting to the proximal phalanx, right? As the name is saying, it is the adductor. So it is called adduction. What is adduction of the thumb? This is abduction, this is adduction. Abduction, adduction, right?
Dr. Irshad, just one more time, could you show?
This is the plane, right? Horizontal plane. If you go away from the plane, this is the abduction, and this is adduction, right? So adduction, that is pulling back the thumb to the palm, this is done by adductor muscle, right? Have you seen a karate movie, Bruce Lee, right?
Yes.
I sometimes see, I tell you that by one thumb and finger, push-ups, right? Can you do it? So your thumb is not very weak structure, so very powerful. Now come to the muscles of the digiti minimi, right? Oh, sorry. Still, abductor pollicis brevis, flexor pollicis brevis. Now going to each muscle. It's a common origin. All these thenar and hypothenar, they are arising from the flexor retinaculum, right? And they are inserting where? They're all inserting to the proximal phalanx, right? Proximal phalanx. Same 3-3. Except opponents. Opponents, it arises from here, flexor retinaculum, but it insert to the shaft of the metacarpal. Opponents pollicis, origin flexor retinaculum, insertion shaft of the metacarpal of the bone. Which metacarpal bone? 1, 2, 3, 4, 5. Opponents pollicis of the thenar, opponents pollicis of the hypothenar. So when thenar is the thumb, first metacarpal. So origin from flexor retinaculum, insert to the first metacarpal. Origin from the flexor retinaculum, insert to the shaft of the fifth metacarpal. First for here, for the thumb, and fifth for the hypothenar. This is very simple action of the thumb. Abduction, adduction. Extension, flexion. So in the same plane, abduction, adduction. Flexion, extension, flexion, flexion and extension, right? Flexion, extension. And opposition and reposition. Opposition, when you are touching thumb and the little finger, this is the opposition. So this opponent's pollicis and opponent's digiti minimi both perform the opponent's action, right? And reposition means when your thumb is the same plane with all the digits, right? So this is the reposition. Short muscles again. If I ask you, what is the nerve supply of the opponent's digiti minimi? Nerve supply of opponent's digiti minimi? Ulnar? Opponent's digiti minimi. Nerve supply?
median nerve. Median, trust me.
Oh, how many? Median nerve. Opponent's digiti minimi. Ulnar, raise your hand.
Ulnar, 100% Ulnar.
Ulnar, yes or no? Raise your hand. Yes?
Yes.
Okay. Opponent's pollicis. Opponent's pollicis.
Median. For sure, 100%.
Open.
Median, raise your hand.
Median.
So in the exam, they will play like this. You know, thenar, three muscle, F, A, O of the thenar is innervated by the median.
Yes, sir.
This is the only exception in the hand muscles. The rest of all the muscles, whether is the hypothenar muscle, lumbrical, interosseous, all are there, right? Except these three. F, A, O of thenar, not of the hypothenar.
Doctor, the FAO are like flexor, abductor, opponents?
Yes,
Policies.
So the,
all complete names.
so the adductor in the thenar is ulnar.
Answer this. You are talking about adductor?
Yes.
Yes. So adductor,
Yes.
it is a fourth muscle of the thenar,
Yes.
but it is the
Ulnar.
ulnar.
It is.
Adductor, ulnar.
It is. Abductor pulses.
So FAO is usually the three muscle innervated by the median nerve of the thenar, right? But the fourth muscle of the thenar, it is considered as the fourth muscle of the thenar, right? So the adductor is also working as the thenar group of muscles, right? Although it is the deepest muscle, right? The FAO, when you go to the model and try to identify, how you will identify? FAO. O in the alphabetical order, it comes last, very deep. So O is the deepest, and F and A both are superficial, right? F and A are superficial, O is deep.
Okay.
Both in the thenar and hypothenar. And in the thenar, the deepest is the adductor, or you can say it's the same level, opponens and the adductor pollicis. Adductor pollicis, this oblique end. Clear? Nerve supply clear? Yes? No? Yes. Tell me about the hand.
Wonderful person.
All muscles of the hand are innervated by which one nerve? All muscles of the hand, they are nerve supplied by ulnar. Very good. But there are three exceptions.
Salimi.
Thenar, right? Three muscles of the thenar. FAO. Right? The fourth adductor, again ulnar. Clear?
Clear.
Okay. Good. Okay, now flexor digiti minimi. Now digiti minimi, hypothenar. Right? Same, FAO. Flexor digiti minimi, this opponens digiti minimi, and FA, abductor.
أقول له يسكر دي الذاكرة في البيت.
Where is the abductor? This abductor, right? So just remember all these things and the nerve supply.
شوف قال لك.
So nerve supply is same. So abductor, digiti minimi, origin, pisiform bone, flexor retinaculum. So when you say flexor retinaculum, and why pisiform here? He's saying because this is the digiti minimi. Yes. So you can blame anyone. Flexor retinaculum, pisiform, or hook of Hammett, everything except.
Blame everything.
Okay.
والله حلو
Flexor
الصراحة.
digiti minimi, opponents digiti minimi. Opponents of any origin, flexor retinaculum, but for opponents, because they are opposite, they are actually on the shaft of the metacarpal, right? So medial opponents digiti minimi, medial border of the fifth metacarpal bone. Oh,
Blame anyone. Can't I?
okay, man.
أهم شيء اللامبريكلز والله أهم شيء.
Sometimes they put the words just to make the MCQ. Cupping palm. Cupping palm means just you lay the like this. This is the cupping. So cupping, okay, more curved. So okay, opponents is like this. So by this you can make cup shape of the palm.
والله العظيم.
Lumbricals, 4. So lumbricals, their origin is from the tendon of the flexor digitorum profundus, right? So all these are the tendons of the flexor digitorum profundus, and they are originating. In the exam, they can play like these two are bipinnate, medial two, and lateral two are unipinnate. This is one MCQ you can make.
That's right.
Yes. So the medial two are bipinnate, and the lateral two are unipinnate.
Oh.
Out of 4 lumbricals. This is the origin. They are all inserting. The origin and insertion both are on the radial side of the tendon. So this is the medial side, this is the radial side. ulnar side, radial side. So if you will see the oil rising from here, okay, bipinnate, both the tendons, single, they are arising from the radial surface of the tendon, and all are inserting to the radial surface of the proximal phalanx. So it is going here, 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 here. All on the radial side of the proximal phalanx. Yes, sorry. You are right. Actually, they are going and attached to the radial side of the dorsal expansion or extensor expansion. Yes.
Are we saying that the nerve is supplying 1.5 muscle because of that?
I don't know.
Who knows?
So we have 2 by, and the first one we have 2.
Yeah, you are brilliant, mashallah. It has increased in my knowledge.
هذه هي فكرتي والله هذه هي فكرتي.
It's why the Allah is providing these two, maybe because these are bipinnate here, and the other two are unipinnate, so may not like unipinnate. So Allah will say, "Oh no, I want bipinnate," right? Just create logic. That's all.
Doctor.
Otherwise, God ask from a God in Tahajjud. Oh God, what is this reason? You have developed this thing. It's coming this Zen.
So maybe that's the reason that in terms of index and the middle finger, it's not that significant in terms of extending these 2 fingers. Because it's unipinnate.
Look, this is another. Thank you very much. We learn from each other. So students also teach the teachers, right? So since they are powerful,
Unipinnate, so it's
right?
not that
So
powerful.
their action will be more powerful, and these are very small, right? Unipinnate, mashallah. Okay, I can make this MCQ. It's really logical.
هنا
mashallah.
bipinnate
Good.
فهذه يصير
Clear?
extension.
Origin, insertion,
هنا
nerve supply,
unipinnate هذول
action.
أصبعين
Right?
of extension أضعف من هذول الاثنين.
Interossei. Inter means between, osseous means bones. Which bones? Metacarpals, right? So they are arising between the metacarpals, and their function is pad. Pad is P, palmar interossei,
Adduction.
and AD, adduction. So all the palmar, these 4, they will do adduction. What is adduction?
This.
Yes, means this is abduction and adduction is together. So if you show me your hand. Okay, like this. If I want to, this is the center, right? Center. Now you want to pull this towards this, and this towards this. So the insertional pull, the point of attachment will be where? On the medial side or on the lateral side? Means on the ulnar side or on the radial side?
On the lateral too.
Open it. I want to pull this towards the midline. So from where I should pull it?
Laterally.
From this side or this side?
From the lateral side.
This side?
Contralateral side.
You pull it toward here.
Yes. Because if I pull it from here, the finger will go here. Right? Similarly, for this one, the insertion tendon of the palmar interossei, it will insert here for this finger, so that when it will pull it like this for this, but these two opposite, because this need to come here, so it should attach here. Pull it here, then it will go here, and for this again it will attach here. Understood? The insertion.
Dr. Irshad,
So adduction, you need insertion because this is the central axis. This there is no attachment to the palmar interossei because it is in the center. Okay, I don't need. I will stand. Okay. But all these 4 muscles, they are pulled toward the center. So how they are pulling? They are pulling it, attaching to the radial side for these 2. Radial side, these 2. But for these 2, opposite. Yes. So this will go and rest on the ulnar side. And this is also on the ulnar side. Clear? So adductors, their insertion, just when the exam comes, they ask about something insertional pattern of the palmar interossei on the anterior side, posterior side, radial side, or lateral or ulnar side. So you should remember which side is this. These are radius. So this is the radial surface, radial surface, radial surface, radial, radial, right? So in making them in the center, so you be very clear which surface, which tendon, which interossei will attach or insert to which surface. Radial surface of the proximal phalanx or lateral surface. If you see the other, there is the palmar interossei for adduction. Now look at the dorsal interossei. Dorsal interossei, DAB. D, dorsal interossei. AB, abduction. What is abduction? Away. Now, for away, just attach oppositely. Right? So, for keeping this finger away from this, you have to pull it from here. Okay, for this one, if you pull it away, this is here.
What about the last one?
Okay, for this thumb and little finger, we are discussing the interossei. For these two fingers, there is a separate abductors.
Oh yeah.
Abductor digiti minimi, abductor pollicis longus or brevis, right? So for these two, abduction is done by the muscles, and for the remaining, they are by the interossei. But in the dorsal interossei, look at the pattern here. In the palmar interossei, there was no attachment of the interossei to the middle finger. But here, on both the sides, just to keep it firm in the center, right? You don't move, right? So here, they are pulling from both the sides, and so this is the thing. So one attached here, second one attached here, third one attached here, fourth one is attached here. This and this, no attachment for the interossei because they are attached with separate muscle, right? So this abductor, pollicis brevis and longus. So abductors, pollicis, longus is here, and for digiti minimi, again there is a on the dorsal side abductor digiti minimi. So you can understand this, right? Particularly the attachment. Just think, if you want to abduct, these two, they have their own muscle, right? And you have to fix the middle one. So two interossei will be fixed into medial and lateral sides.
Yes, sir.
Right? But the portion is only these two, they are attached. For abduction, it should be insert here on the radial side, and this for the ulnar side, right? All need some at home revision. So inshallah I will have. So facial spaces, sinus, cavities, right?
One of the objectives.
God has made this very typical. Hand is very skilled structure. Very fine movement is there. Many muscles, small muscle, long muscles, right? So God has just made the compartments of the upper limb, right? Arm and forearm. This hand, palm area is also compartmentalized. Why? Because any infection, if some nail, tuck, 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 right? If nail pierces here, its infection, its sepsis, the pus should be limited to this thenar area. If it is in the center, its pus should be limited to the middle area. Should not go here and the whole hand become disabled, right? So just to avoid this thing, God has made compartmentalization. How? If you will see the upper figure,
نحتاج مساعدة أو مساعدة وزير الطاقة.
I want to show you the enlarged picture of this. How I can show.
قلت
الكهرباء.
كهرباء صحيح مطلقة. هو نفس الشيء. بسم الله.
الميم صح؟
لا.
بوريك يا بدر بس.
Here, just like the arm, the compartmentalization of the arm and forearm is by the D fascia, right? So D fascia, the fascia, they are coming down and attached to the bone, right? Here is the same pattern. What we need to observe. This is what red color, palmar aponeurosis. Palmar aponeurosis, right? It's a facial sheath, and from that sheath goes down the fibrous sheath. If you see here, can you see this one going down, 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 and attached to this bone?
Yes.
This is the fifth metacarpal. So this is one septum, right? Another septum from this fibrous sheath, palmar aponeurosis, is this one. Look at this. Third. So third and fifth. So this is one compartment, right? And this space is called as the mid-palmar space. And from this here, you can see this very big area. This is the green color here, thenar space. So this is the thenar space. These are the muscles, and the gap between the muscles, the space between the muscles. So it is pointing this area. So actually this is all between the first and this septum, lateral fibrous septum, and this is the medial fibrous septum. So lateral and medial fibrous septum are the extension of the palmar aponeurosis. Palmar aponeurosis. And they insert the lateral fibrous septum, it attaches to the third metacarpal, and the medial fibrous septum, it attaches to the fifth metacarpal, right? So this area, this must be the thenar space with the thenar muscles. This is the mid-palmar space with all the tendons, lumbricals, right? Interossei, right? And there is a small space, free space here. And this is the thenar space with some small space between the muscles and the other structure. Clear? So these are called as the palmar spaces.
يعني filled of air ولا إيش؟ filled with air هواء سوائل
لا ولا شيء.
سوائل
ولا شيء.
كيف ولا شيء؟
Blood
هي
vessels.
لو وصل فيها شيء.
Blood vessel. Okay. For anatomical point of view, a radial artery coming from here, running on the lateral side, and then when it comes near the wrist, it goes back. A radial artery running on the anterior, before the carpal, it goes back. And how? It crosses the snuff box. It travels or traverses the snuff box, touching the scaphoid bone, right? Because the scaphoid bone and the trapezium, they are forming the, scaphoid bone, trapezium, they are forming the floor of the snuff box, right? So this radial artery, it goes back through the snuff box, touching the scaphoid, and when it comes at the dorsum, now this radial artery contributes in the formation of deep palmar arch. Deep palmar arch, right? So it has to move here, anterior. So between the thumb and the index finger, the muscles here, this first is the first dorsal interossei. It is not shown here. So first dorsal interossei is again a bipinnate. So between the two heads there is a gap. So this radial artery, after traversing through the snuff box, passes through the two head of the first dorsal interossei and come here on the palm. And when it comes here in the palm, it passes through the two heads of the adductor pollicis, right? So this is one important MCQ. The deep palmar arch is formed by the branch of the radial artery passing through the two heads of which muscle? In the palm. Yes, adductor pollicis. And in the dorsum of the hand, the back, the first dorsal interosseous.
Doctor, the deep palmar arch is between the what? The adductor pulses?
Yeah, this is the deep palmar arch.
Yes.
This artery is between the two heads of adductor
Adductor
Right.
pollicis.
in the palm area. But when it is on the dorsum and it needs to come to the palm, here it penetrates between the two heads of the first dorsal interossei. Dorsal interossei.
2 slides before.
Hmm?
It's in the 2 slides before the first dorsal interossea.
Okay. Radial artery and ulnar artery. You are talking about back. This
Yes, the radial artery passes here.
The first dorsal.
first dorsal interossei. Right? This is also good. So this is what? The same radial artery, but this is the dorsum. It's showing because these are dorsal interossei, so they are showing picture from the dorsum. So this is the first dorsal interossei. This is the radial artery. Okay. There is still an anterior view, right? Because this artery is going back. Here it is light, showing back. So when it's back, it means this is the front, right? So it's passing through the snub box, but this is the palm area. So when to enter into the palm, it is tilting like this between the two heads of the first dorsal interossei. Again, the only clinical thing that is important here is this dash line, index finger. Index finger and on the medial side, mainly supplied by the ulnar artery.
Yeah.
Medial index and thumb by the radial,
Yeah.
right?
Yeah. Also كفي كده.
So this is the radial artery. It is penetrating through the first dorsal interossei, right? Radial artery passing through the snuff box. This is the three tendons, right?
مسافة المخالف أقوى.
Okay. Another question comes: formation of the superficial and deep palmar arch.
Contribute.
Which one is this? This is superficial,
Yes.
and this is deep. The ulnar form the superficial, and the deep is mainly formed by the radial. So just remember, mainly form, because both of them they are giving branch. So this is the ulnar main. It will extend up and form the superficial,
Yes,
and
sir.
superficial will go like this.
Yes, sir. Yes.
It will connect with the superficial.
Nerves of
uh,
hand. Nerves of hand.
This artery.
Oh, بس ده صعد.
This is the superficial branch of the radial artery.
ناخذ ضرب من ذيك.
This is the deep branch of the ulnar artery. So deep branch will go and anastomose with the deep branch of the radial artery. So just remember like this, that superficial is mainly contributed by the ulnar and deep is mainly contributed by the radial, right? That's all I think. Oh.
Oh man.
So these are again the nerve supply. Same thing we have discussed a lot. Ulnar nerve, two branches, superficial and deep. deep branch, they are motor, superficial. When we say superficial branches of the nerve, it is cutaneous branches. Cutaneous means sensory branches, right? So mainly cutaneous, mainly superficial, they're all sensory. But when you go to the deep, it means they are muscle supplying muscles, they are motor. So penetrate and supply the hypothenar muscles, supply the interossei, two lumbricals, class. Superficial innervates palmaris brevis. Palmaris brevis was one muscle like platysma here. So it was arising from the flexor retinaculum and attached to the dermis of the skin, right? And it is a horizontal muscle.
All right. Cool.
Another. Median nerve. Some clinical question comes with the branches of the median nerve. If you see here, there is a trick. Median nerve, and before the flexor retinaculum, it go below in the tunnel, carpal tunnel, it gives a branch, this palmar branch. And this is the sensory, cutaneous. But it is cutaneous only to the thenar area, not going to the digits. So this is a very small branch, but this branch, sensory branch, is above the flexor retinaculum, right? That's why when there is a carpal tunnel syndrome and the median nerve is compressed, the sensation of the thenar is intact. Why intact? Because the superficial branch is before entering into the tunnel. So it has given this branch, sensory, and it will carry the sensation, no problem. The problem comes with there's a main artery, the main nerve going below the tunnel, compressed, and as this nerve come out, it give a recurrent. The recurrent, I told you, when you have crossed your destination, you think, oh, I have to go back. So you make a U-turn, right? So this is the U-turn, that this nerve has passed the thenar, but then say, oh, I have to supply the thenar muscles. So it come back, right? So these recurrent branches are all like this. Elbow, cross the elbow, then you think, oh, I have to give the blood supply. So recurrent branches of the. So this is the nerve, the recurrent nerve supplying the three muscles, not the four, right? Adductor by the ulnar. So this is the motor branch, and these one, they will go and innervate the skin. Median nerve. So if you see, this is showing palmar branch. So palmar branch is innervating the thenar area. So this is the palmar branch supplying this. So this area sensation is intact in the carpal tunnel syndrome, right? But the digitals, right? These green, these are these green branches, right? These are the digital branches that are supplying the skin. So this is the 3.5, lateral 3.5 on the palm side, innervated by the median nerve, and on the dorsal, the distal phalanx, right? The distal phalanx, keep it like this, is the median nerve innervation. The radial nerve.
Last slide. Let's go.
Radial nerve is passing through this snuff box. Radial artery, radial nerve, right? Both are running in the snuff box. Radial artery touches the bone. Radial nerve is running along the snuff box, not necessarily touching the bone. So, but then superficial branch of radial.
Sure.
Okay, what is this superficial branch and the deep branch of the radial nerve?
So the deep branch goes to the supinator.
Yes. When is this division occur? Deep branch of the radial nerve, superficial branch of the
Between the two heads.
between two heads of
Supinator.
supinator.
Yes, sir.
Right? So supinator is here. So this nerve, in some books, it says that this nerve pierces the supinator. Pierces, right? But actually it passing between the two heads, right? And while before passing to the muscle, it divides into two branches, superficial and deep. So superficial goes above the supinator muscle, and the deep go between the two heads and supply all the extensor muscles. So here when he is saying superficial or superficial, so this is means is talking about the cutaneous, right? That's why it is showing this whole large area, except the proximal digits
Tips.
supplied by the median nerve. So okay, fine. So any question?
Yeah.
So lateral 3 and 1/2 digits approximately.
Thank you so much. Goodbye. Good night.
خلاص؟
خلاص كردش.
ما شاء الله.